Hey everyone, and welcome to my YouTube channel, Medicine with Zaid. I'll be your host, Vincenzo. I'm just kidding. I'm Zaid. I'm a medical doctor from the UK. I set up this channel to try and teach some of the more difficult subjects in medicine. I think that there's a lot of subjects that are poorly taught or poorly understood, and there's a lot of subjects that people just try to learn to pass for an exam, so they never really understand it. And this became really obvious to me when I was studying for my MRCP exams. These are postgraduate exams for medicine in the UK, and I came across the subject of glomerular nephropathies. It's the most complicated, convoluted subject, and having talked to my peers about it, it's obvious that no one really knows what is going on, but they'll learn certain things to try and pass an exam. And that's why I set up this channel, to try and explain some of these subjects for you to actually understand them and actually know quite a lot about them. I love medicine, it's my biggest passion, and this YouTube channel is just a good reason for me to keep studying, but to also try and impart on you some of the more clinical aspects of certain subjects and to try and explain them in a way that is easier to digest. So as I said, I'm a medical doctor from the UK. I love medicine. I want to specialise in potentially palliative medicine or geriatric medicine or maybe even acute medicine, but I have a special interest in cardiology, gastroenterology, respiratory, endocrinology, neurology, rheumatology. I kind of like everything, to be honest. Not a big fan of renal medicine though, but having studied all of renal and glomerular nephropathies, I like it a lot more. It's actually not as bad as you think, and the trick to understanding renal medicine is to learn it in depth. And I know that sounds daunting, but it's the only way to ever understand it. So, it's the beginning of April, and it's the COVID-19 pandemic. And I'm actually off sick, self-isolating, so I'm a bit more nasally than usual, but I'm sure you can understand what I'm saying. My friends ask me, "So Zaid, what are you doing to spend your time whilst you're off sick?" I tell them, I'm a cool guy. I spend time DJing, I spend time on the Xbox, watching Netflix documentaries. But in reality, I'm sat at home studying, doing this YouTube channel for you, because I love to teach. And I hope you find it useful. So to start with, we'll talk about renal medicine generally. Renal medicine is quite complex, and there's a lot of terminology I think we should get out of the way before we start. Because I'll be teaching this to a postgraduate level, I want this to be suitable for medical students to digest as well. And the problem with medicine, which I found in particular as one of the first and second year medical students, was I had no idea what people were talking about. It was taught to such a high level, and the language we used, it just sounded like Mandarin to me. So I do want you to appreciate that this YouTube channel won't necessarily teach you the very nitty-gritty basics, but it'll explain most topics in enough detail for any medical student, plenty of detail for postgraduate doctors, and hopefully the language I'll use won't be too difficult for medical students, and I'll try and explain most of the terminology in the beginning of each video that I'll be using for you to understand. But the niche that I want to put across in my YouTube channel is explaining things in a more clinical focused way, in a way that will help you in your actual clinical practice in reality as a doctor. This focus often isn't thought of when it's being taught in medical school. We often learn about subjects without really appreciating how common they are in reality, or how important they are in reality, or how much we really need to know as doctors. So I will try and explain a lot of that for you. So that's enough of the introduction. I hope you find the channel useful. An acute kidney injury is essentially anything that will reduce the renal function, which we will define as an increase in creatinine, which is just a breakdown product that the body makes. So when you see a rise in creatinine, 50% or more from their normal or their baseline, you have someone with an acute kidney injury. Essentially, this just means that the kidneys aren't filtering things as well as they're supposed to, and a lot of the stuff that they're trying to get rid of remain in the bloodstream. An acute kidney injury is divided up into three broad types: pre-renal, intrinsic, and post-renal. But we'll talk more about that later. CKD, or chronic kidney disease, is essentially a reduction in the function of the kidneys, their ability to filter things out from the bloodstream. So you have a higher level creatinine than people of the same age, height, race than you, for example. It can be caused by things besides acute kidney injuries. It can be caused by long-term damage to the body and to the kidneys, for example. This could be a lifelong hypertension or lifelong diabetes. Diabetes can cause CKD over a sort of years, but if you have really, really bad high blood pressure as well, this can happen over years as well. Hypertension and diabetes are some of the leading causes of chronic kidney disease and end-stage renal failure. End-stage renal failure is essentially the point at which the kidneys aren't able to function at a level for human life, or should I say quality of life as well. So one of the breakdown products that we need to get rid of by the kidneys is urea. And if urea is too high, it can make you really fatigued, feel unwell, nauseous, itchy, and it can even cause you to have encephalopathy and pericarditis. It's a very serious problem, and there's a lot of breakdown products and even the metabolism of certain drugs that needs to happen in the kidneys. So end-stage renal failure will require something to take its place. If the kidneys can't do their job, we need to dialyze the patient. We need to give them dialysis, which is a form of renal replacement therapy. So renal replacement therapy is something we do for people who don't have enough functioning kidney to do the job. But remember, the kidneys are responsible for more than just filtering the blood. They are also responsible for your bone health because they're involved in vitamin D and calcium metabolism, but they're also responsible for your blood because they create erythropoietin. And erythropoiesis is the process by which we make the hormone erythropoietin to stimulate blood growth in the bone marrow. So the kidneys are obviously very important. End-stage renal failure, there are 5 main causes. They are glomerulonephropathies, obviously, but more commonly, they're caused by hypertension, diabetes, post-renal failure, so anything that obstructs the flow of urine down to the kidneys, because anything that obstructs the flow will cause a hydronephrosis, a dilation of the ureters, and will eventually cause a backflow and damage into the kidneys. This can be caused by anything that causes an outflow obstruction. So that could be a problem in the bladder, there could be a malignancy, a tumor in the bladder obstructing it, it could be kidney stones, it could be a big prostate, or it could just be urine retention. And that can be acute or it can be chronic as well. So, those are the causes of post-renal failure, obstructive uropathies. And the last cause of end-stage renal failure, of the 5 main causes, which are, glomerulonephropathies, hypertension, diabetes, I forgot now what I was talking about, and post-renal syndrome. The last cause is polycystic kidney disease. This is a generally autosomal dominant condition, and it's associated with massive cysts that develop usually sort of in late adolescence, and essentially these cysts are just massive, and they sort of take up a lot of the space in the kidneys, and they replace good healthy kidney tissue and eventually lead to end-stage renal failure. These patients often have a lot of liver cysts as well, and it can be associated with aneurysms in the brain and therefore intracranial hemorrhage. And there are some other associations, like with tuberous sclerosis, for example. But that's all I wanted to talk about for other major causes of kidney disease, because glomerulonephropathies is actually a relatively uncommon problem to cause kidney disease and end-stage renal failure relative to all the other causes. But it is very popular in exams, however. And it's just funny because the things that don't come up as much in clinical practice are the things that they ask about in exams. Now, I will be speaking a lot about disease course, relapse, remit, etiology, pathology, histology, and it's important to know what all of these things mean. Etiology is essentially the process by which a disease happens, so the pathological process that causes a disease to happen. A disease is essentially the result of a pathological process. So a certain etiology will cause a disease, and a disease will cause a certain effect on someone. A disease course is essentially the journey that a disease takes a person through and how it affects them over time and what it seems to cause in terms of symptoms and complications. So a disease course might be the disease starts out as quite benign, but then it gets progressively worse and it will result in end-stage renal failure. But then a disease course could be altered or changed by, for example, treatment. So we can try and induce remission in a disease. And remission just means that the disease process has stopped, the pathological process has stopped. Now, remission sort of suggests that this is a disease that can come back. It can relapse. And relapse just means, when you've had it once and it either resolves by itself or you treat it and it resolves, goes into remission, but then it comes back. We can try and induce remission, create remission with treatment. And in renal disease or glomerulonephropathies, which I'll talk about more later, we can try and induce remission with immunosuppressive therapy. Okay, immunosuppressive therapy is important for many, many diseases in many, different organs. So any autoimmune disease, more or less, can be treated with immunosuppressive therapy. And most of the kidney diseases that aren't caused by secondary things like drugs or infections, they can be treated with immunosuppressive therapy. Immunosuppressive therapy is made up of essentially steroids, but also other drugs. They could be cytotoxics, which are basically chemotherapies like cyclophosphamide. And this can be quite a nasty kind of drug to take. It is a chemotherapy. It can predispose people to cancer. It can cause them to have premature ovarian failure, for example, teratogenicity, and all sorts of problems like bone marrow failure. We then also have other drugs such as calcineurin inhibitors, and these are less toxic, but they're still very toxic, and they can even affect kidney function. All of these drugs obviously can affect your immune system and predispose you to getting infections. The most important immunosuppressive drug, which we use for so many different things, are steroids. And when I say steroids, I'm talking about glucocorticoids, not mineralocorticoids, not anabolic steroids like, buff gym dudes shooting up. I'm talking about glucocorticoids. So we have endogenous glucocorticoids, cortisol, but we also take exogenous ones, the drug. And this will usually be in the form of something like prednisolone. But if someone is unwell and in hospital and they're not able to eat, or you need to give them a really potent, really strong steroid to try and sort this patient out, induce remission, you can use different drugs. You can use things like methylprednisolone, which is an intravenous version of steroid, and it's incredibly potent. But remember, all of these drugs have side effects. Steroids in particular, they can cause diabetes, weight gain, high blood pressure, infections, thin skin, depression, changes in menstruation. They cause so many problems. So, treating these diseases has their own problems, and you have to weigh up, if someone's disease is, something that might not be treatable, or you think treating it may cause more harm than good, then, maybe you shouldn't treat it. Obviously, a lot of these decisions will be made by the renal doctors, but I'm just speaking generally because you, as a medical student or a doctor, will one day probably be using these drugs and making these decisions yourself, as immunosuppressive therapy is used in so many different branches of medicine for so many different diseases. Some of the other terminology I'll be using will be things like glomerular nephropathies, glomerulonephritis, nephrotic syndrome, nephritic syndrome, proteinuria, hematuria. All of these things I'll be talking about more in this video, so just hold on. Now I'm going to talk very quickly about AKI. I say very quickly now, it's probably going to be quite a long time. But AKI, as I said, divided up into pre-renal, intrinsic and post-renal. Pre-renal is essentially caused by dehydration or hypovolemia. There's not enough fluid, or should I say water, in the blood, and therefore the kidneys aren't being perfused well. And we treat that with fluids. It can be orally or it can be intravenous. It depends on how severe it is and whether or not the patient is able to tolerate fluids. The next cause is intrinsic, and that's caused by, drugs, for example, but it can also be caused by glomerular nephropathies, and this is what we're going to talk about today. The last cause is post-renal failure, which I've already discussed. So when you're assessing a patient with AKI, it's really important to take a history, see if you can have a cause told to you by the patient. Maybe they told you they've had gastroenteritis, they haven't been able to keep fluids down. Maybe the history is that they've just had a surgery and they've probably had some blood loss and dehydration. Or maybe they'll give you a family history of kidney disease, and they haven't had any dehydration, they haven't had any problems passing urine, and you think this is actually a glomerular nephropathy. You should also assess their fluid status. Fluid status is really important. You can't really assess renal function or the cause of acute kidney injury without assessing their fluid status. You should be looking at their mucous membranes. Are they dry? You should be looking at their JVP. Are they fluid overload? Do they have fluid in their legs? Have they got fluid in their chest with some basal crepitations? And the other thing is examine their abdomen. Make sure they haven't got a palpable bladder, as acute urinary retention is a very common cause of post-renal failure, especially with unwell patients in hospital. Have they got a urine infection? This is, I think, a clinical diagnosis, and the patient will usually tell you if they have symptoms. Don't rely on dipping the urine to find out if they have a urine infection, as it's not sensitive or specific in older patients, which are the majority of the people we see. The other thing is look at their drugs. Nephrotoxic drugs are often a cause of acute kidney injury, but we should also be holding these drugs in any acute kidney injury as well, to give the kidneys a chance to get better. Any new drugs could be causes, and it's always worth looking up if they are known to cause kidney failure. When you have a patient with acute kidney injury, always dip their urine, because you want to be screening for nephrotic or nephritic syndrome, which are essentially syndromes which cause protein or blood in urine, and I'll talk more about them later. It can also help you screen for urine infection if they're quite a young patient and you think it would be a sensitive test, or a specific test even. You want to be doing blood tests to look at their renal function over the next few days as you treat the underlying cause. So if you think they're dry, give them fluids. If you think it's post-renal and they have urinary retention, you put a catheter in. If you think it's a post-renal failure but you're not sure what it is, you might want to get an ultrasound of their kidneys, urethra and bladder, an ultrasound of their urinary tract to see if there's anything there. It could be a kidney stone, it could be malignancy. Do you need a non-contrast CT scan to see if there is any involvement of those things? Lastly, if you think this is an intrinsic cause, i.e. this could be nephrotic syndrome, nephritic syndrome due to glomerular nephropathy, you need to be taking a good history, you need to take a family history, and you should do a renal screen. And a renal screen is essentially a set of blood tests and also a urine test as well, which try and find some of the secondary causes and also, some of the primary causes of glomerular nephropathies. So it will include creatinine kinase, have they had a rhabdomyolysis, for example. It will include ANA, ANCA, so you can have ANCA-associated vasculitises that cause glomerular nephropathies. You can have ANA, which is associated with lupus, which can cause it. You do a complement screen as well. Complement is often associated with lupus and also, complement deposit disease in glomerular nephropathies. And then you do immunoglobulins, you're thinking about myeloma. You do rheumatoid factor, for example. You want to do Bence-Jones proteins, and I'm just wondering if there's anything else. But those are the main things anyway. The other thing is you should be talking to a renal doctor if you're worried about this being an intrinsic cause. If it's, they've taken some ibuprofen and it's getting better now, then you don't really need to worry. But any patient who has a nephrotic or nephritic syndrome, or they have a glomerulonephropathy, or they have worsening renal function and you can't treat it, you can't explain it, you should be talking to a renal doctor. Do the renal screen early in this context, as many of these tests take a long time to come back. I've just remembered the other thing on the renal screen. You want to do an anti-GBM, which is essentially an antibody which is seen in some of the more rapidly progressive forms of glomerulonephropathy. So, moving on. Any patient with quite a bad kidney failure, you should always be checking to see if they have a metabolic acidosis. You should do a blood gas on them, as obviously the kidneys are responsible for making bicarbonate, and if they're failing, they might not do a good job at this, and they may have a metabolic acidosis, which can be severe, but it is treatable to a certain extent with oral or intravenous bicarbonate. But if their kidney failure is bad enough and they don't respond and they still have a metabolic acidosis, they may require dialysis. Dialysis is something you should be thinking about in patients with really severe renal function. Patients with an EGFR less than 5, you should start to be thinking about it. But the indications for dialysis are patients with refractory hyperkalemia, patients with refractory fluid overload, patients with uremic symptoms that have encephalopathy or pericarditis. These are the sorts of indications you need to be thinking of. And that also prompts me to say that you should also be monitoring their potassium, which you will be doing with their ureas and electrolytes every day if you're monitoring their renal function. But potassium is something that can go up and be quite a dangerous complication of an acute kidney injury, and also a complication of patients with chronic kidney disease as well, if it's bad enough.